So today I'm going to cover the topics neoplasia, immunology, inflammation, vascular pathology, vascular and blood pathology, GI pathology, general pathology, as well as bone. So let's go for the neoplasia. If you go for the cell cycle, whenever a cell is there, how it is growing, the cell has got initial G0 is the resting phase, that is called as quiescent phase. Then G1 is a gap phase, it is pre-synthetic. G1 gap, G2 gap. G1 and P53 gene is important in this. Then there is S phase, during which there is synthesis of DNA, chromosome replication. Here DNA is replicated, and there is again gap, that is G2 phase, pre-mitotic. Mitotic means before division. Mitotic. Cells contain twice DNA. DNA has multiplied and here 2 DNAs. Then there is mitosis and cell division. This is the cell cycle. So neoplasia. What is neoplasia? Neoplasia is a lesion resulting from abnormal growth of tissue which is partly completely autonomous. It is autonomous. Tumor classified as benign or malignant based on the behavior of histogenic. Their behavior or there is histogenic classification based on cell level. Major categories of the tumor are from the epithelial cell, connective tissue, lymphoid, and hemopoietic tissue. 3 different types of cells: epithelial, connective, lymphoid. Differentiation in degree into which tumor histologically resembles tall cell of origin. Well differentiated means it is looking like a parent tissue. Poor differentiated is easily less differentiated and moderately differentiated. Definitions: hypertrophy, increase in cell size without number, is size is increased. Hyperplasia is increase in number of cells, can be physiological or pathological. And metaplasia is, what is metaplasia? It is reversible one cell type to another, adaptation to different. Dysplasia, altered cell maturation. Anaplasia, to form backward, lack of differentiation, hallmarks of malignancy. So if you see the neoplasia, cells of tumor epithelium well differentiated resembles poorly differentiated. You can cell get adapted into atrophy if the cell size is reduced. Hypertrophy, size is increased. Hyperplasia, number is increased. Metaplasia, from one type of columnar to squamous, that is metaplasia. Dysplasia, there is irregularity, and definitions of are atrophy, size. Example of the atrophy is muscle hypertrophy. Examples of hyperplasia is endometrial hyperplasia, dysplasia, metaplasia one type to another, cervical metaplasia, glandular to squamous, dysplasia, altered cell mutation, orientation. Now, what are the microscopic change in the shape and size orientation can progress to carcinoma, cervical dysplasia. Microscopic features of dysplasia are how can you differentiate this? What are the features of dysplasia? Pleomorphism, variation in the size and shape. Nucleus get hyperchromatic. Mitosis is increase in number, look, position, not confined to basal layer. Loss of cell to cell cohesion, loss of architecture, no invasion to underlying connective tissue. So this is dysplasia microscopy. There is no invasion. If there is invasion, it is clear-cut carcinoma. Behavioral of malignant and benign tumors. How are the benign? Regarding growth, slow, benign are slow, malignant are rapid. Mitosis is low, high resemblance of the parent tissue, normal cell morphology. Non-infiltration, penetration, this benign is non-infiltrating, and this is infiltrating. Spread, it never spreads. This metastasis, shape is circumscribed, poorly differentiated. Ulceration, rare, frequent. Now what is cell death? So let us see. This was regarding benign and tumor. Now here it's given tumor nomenclature. Let's see it afterward. Now what is cell death? Morphological changes. FCPS, short form is formation of cytoplasmic blebs, apoptic bodies, chromatin condensation, phagocytosis, shrinkage of cells. FCPS, physiological, pathological. Regulated by gene product that protect against the apoptosis, BL2 interleukins. The gene product that promote apoptosis is P53 and MYC. We will see tissue of origin, benign, malignant. Here you can see the nomenclature. Tissue of origin, epithelium, mesenchyme. If it is glandular epithelium, benign tumor is adenoma, malignant is adenocarcinoma. If it is squamous epithelium, squamous papilloma, malignancy is squamous cell carcinoma. Transitional epithelium, transitional papilloma, transitional carcinoma. Mesenchymal tissues, fat, muscle, smooth muscle, bone, cartilage. If it is lipoma, liposarcoma, striated muscle, rhabdoma, rhabdomyosarcoma, smooth muscle, leiomyoma, leiomyosarcoma, bone, osteoma, osteosarcoma, cartilage, chondroma, chondrosarcoma. Lesions having cytological features of carcinoma but no invasion through epithelial base membrane are called as carcinoma in situ. Example is ductal carcinoma. A teratoma is germ cell neoplasm, 3 germ layers, ecto, meso and endoderm. Embryonal tumors which are arising from the nephroblastoma, Wilms tumor, neuroblastoma, adrenal medulla tumor, retinoblastoma, eye, hepatoblastoma. Mix more than one neoplastic component. These are pleomorphic adenoma, fibroadenoma of breast, hamartoma, pigmented nevi, pulmonary. How is the tumor growth pattern? Sessile, polypoid, papillary. These are benign. Sessile, polypoid, papillary. If these patterns are there, malignant, they are fungating, ulcerating, annular, infiltrating. Histological features of carcinoma we have seen: loss of differentiation, distorted growth, variable size, nuclear size, cytoplasm nuclear ratio is increased, mitotic activity. Now, carcinogenic agents known to cause suspicion in causing carcinoma. Now we have seen this nomenclature. All OMA, benign epithelial tumors are papillomas, benign connective tissue tumors are osteoma, carcinoma is a malignant neoplasm, sarcoma is malignant connective tissue. Now these are embryonal tumor, nephroblastoma and all that you have seen, pleomorphic adenoma, sessile histological features, loss of differentiation, variable in size. Now main causes of carcinogens. What are the causes of classes of carcinogens? These can be chemical, radiation, viruses, hormones, bacteria, fungi, parasites. Now what are the chemicals? The chemicals that cause carcinogenesis. These are polycyclic hydrocarbons. They cause squamous carcinoma of the scrotal carcinoma. 3,4-benzopyrene, which is present in tobacco, that causes bladder and kidney cancers. Tar is causing skin cancer. Aromatic amines, beta-naphthalene causes bladder cancer. Nitrosamines, genitourinary cancers. Azodized bladder and liver cancers. Alkylating agents, leukemia. Then another cause is radiation. The radiation, ultraviolet, this causes skin cancers. Radiation to the neck causes thyroid cancers. The viruses, oncoviruses, these are the viruses that are associated with the cancers. These are commonly human papilloma virus causes C. cervix, human papilloma 16 in 18, Epstein-Barr virus, Burkitt lymphoma, nasopharyngeal carcinoma, beta cell lymphoma. Then hepatitis B virus, hepatitis cell carcinoma, HIV causes Kaposi sarcoma, human T lymphocyte virus, HTLV, T cell lymphoma and leukemias. Bacteria and fungi, that causes bacteria, fungi and parasites. H. pylori causes gastric lymphoma. Aflatoxins B1 causes hepatocellular carcinoma. Schistosoma, bladder cancer. Other agents, these are asbestos, mesothelioma, bladder, bronchogenic carcinoma, metals, nickel, nasal broncho. Now these are the carcinogens. Now what are the host factors? The host factors are race, the coincidence, diet, habit, location, the diet, aflatoxin containing hepatocellular carcinoma, low fiber diet, colorectal carcinoma, high fiber diet, breast carcinoma, inherited predisposition. Some of the people have common inherited predisposition. This is run in the families. Age is generally incidence of cancer is increasing age, some cancer. Now, some cancer, carcinoma of the breast 200 times more common in women than the cancers which are common in males are prostate cancers and females are breast cancers. Now let's see what are the inherited most of the time familial cancer syndrome, families which are run in the families. Leaf-Romani syndrome, the P53 gene is responsible the malignancies of breast, ovary, sarcoma, astrocytoma. Retinoblastoma gene, RB gene, retinoblastoma, osteosarcoma. Familial polyposis coli, APC gene, GIT cancers. One hyperlymphoid disease, VHL, renal carcinoma, pheochromocytoma. MEN, multiple endocrine neoplasm, RET gene, pituitary, parathyroid, thyroid cancers. Familial breast cancers, BRCA1, BRCA2, breast and ovary. These are the familial malignancies. Now let's go for organ metaplasia undergoing. Now let's see for the pre-malignant lesions convert into malignant, benign to malignant. Colorectal adenoma, it can convert to carcinoma. Dysplasia in situ, it can convert to malignancy. Let's see the organ, which organs has got metaplasia undergoing dysplasia, resulting in malignancy. Esophagus, if you see Barrett's changes, there is squamous metaplasia converted to intestinal metaplasia that may lead to adenocarcinoma of esophagus. Stomach, intestinal metaplasia, again gastric adenocarcinoma. Bronchus, squamous metaplasia, bronchogenic carcinoma. Cervix, squamous metaplasia, squamous cell carcinoma. This has got kidney transition in the epithelium. This causes squamous metaplasia, squamous cell carcinoma. How is carcinogenic process? So this was, let's go for the carcinogenic process. Multi-step therapy, there is latency in the initial phase. Casual event is followed by length of delayed period. Initially there is casual event, then initiation, exposure of the cell to carcinogen, then promotion. Now what are the genetic alterations? You get evidence of genetic alteration causing cancers. Changes in the genetics, translocation, part of one chromosome become attached to another. Example, Philadelphia chromosome, CML. Philadelphia chromosome, chronic myeloid leukemia. Extra chromosome, usually trisomy is 3 copies of chromosome rather than 2. Trisomy 21. Down syndrome, acute leukemia, familial aggregation, retinoblastoma. Family aggregation, retinoblastoma. Increased risk of malignancy associated with the incapacity to repair damage. Now, genetic mechanism. Two important genetic mechanisms leading to neoplasia are abnormal expression of the dominant somatic gene, oncogenes, and abnormal towards the expression of oncogenes drives normal cell towards the neoplastic stage. Loss of inactivation of recessive inhibitory genes. Tumor suppressor genes are lost. Loss of tumor suppressor gene function allows neoplastic transformation, oncogene expression. What are the different oncogenes? Let's see for the oncogenes whose presence in the certain forms activity can stimulate carcinoma. They instruct cells to make protein that stimulate excess growth. Proto-oncogenes gets mutation to form oncogenes. Example of growth factors, PDA, platelet-derived growth factor, epithelial growth factor, erythroblastoma virus, macrophages, colony stimulating. These are the factors which are stimulated. Phelan, McDonald sarcoma virus, transcription factors, MYC DNA binding factor. Now, what are tumor suppressor? Normal genes whose absence causes cancer. Categories depend on mechanism of action. These are caretaker, gatekeeper genes. Individuals who inherit or increase risk of developing cancer. If one pair will cause cancer, will not cause. One's copy will not cause cancer. If second copy undergoes mutation, the cancer may occur because there is no longer a functional copy of gene. Tumor suppression genes associated with tumor. These are the genes. Category genes, gatekeeper genes, Leaf-Romani predisposed to 53. Tumor suppression. Normal genes whose absence can lead to development of the cancer. Tumor suppression genes, again these are gatekeeper. P53 is a category gene tumor susceptibility if mutated other as well. Leaf romanicin produces a widespread tumor breast mutated 50%. Retinoblastoma, familial retinoblastoma, APC, adenopolis BRCA breast. P53 is a tumor suppression situated on the chromosome 17. Most frequently mutated of class gene is most frequently mutated gene. Normal functions are repair of normally it repair DNA before S phase. Initially we say mitosis is there, S phase, G. The phases we have seen by arresting cell cycle in G phase until damage repairs. Apoptic, it causes apoptic cell death if DNA damage is extensive. So there is question regarding this tumor P53 causes apoptosis of the DNA. Inherited germline mutation of P53 occur in leaf Romani syndrome, giving an inherited result to a wide range of tumors. Invasion is sole most important criteria of malignancy. Metastasis occurs. These are the factors affecting tumor invasion include abnormal or increased motility, secretion of proteolytic enzymes, motility, decreased cellular adhesions. So how the metastasis occur? Where malignant tumor spread from one side to the other, distant metastasis tumor spread by the roots. These are different routes of metastasis are lymphatic, hematogenous. One is lymphatic, second is hematogenous, third is seeding. It can seed anywhere in the body. So the structures invaded, and what is the effect? What are the different structures invaded and how does it affect? If it's esophagus, you can see if esophagus is invaded, it leads to dysphagia. Thoracic major vessels invaded, this leads to hemoptysis. Superior cava is invaded, facial edema and cyanosis. Recurrent is hoarseness of voice. Sympathetic chain is invaded, there is Horner's syndrome. Brachial plexus lead to Bianco's tumor. Phrenic nerve paralysis of hemidiaphragm. Pericardium, pericardial effusion. What are the steps in metastasis? Detachment of the tumor cells, invasion surrounding tissue, lumen invasion, invasion of the host defense, adherent to endothelial cell, then extravasation from the vessel into surrounding tissue, survival and growth within the tissue, establish their own blood supply. So these are the steps of invasion. Now paraneoplastic effects means the effects that is caused along with because of tumor malignancy present. These can be hormonal and immunological. Hormonally, tumor secretes some products which leads to hormonal effect, and immunologically is autoimmune. Examples of paraneoplastic effects because of hormonal is bronchogenic carcinoma causing Cushing syndrome, syndrome of inappropriate antidiuretic arrangement AIDH. Then hypercalcemia is caused in parathyroid malignancy, medullary carcinoma, parathyroid. Then carcinoid syndrome with liver metastasis, phytotoxicectomy. These are the hormones secreted which cause paraneoplastic. Immunological autoimmune diseases, trigger of malignancy, dermatomyositis, membranous glomerulonephritis. Other effects, cachexia, all tumors are multifactorial, unknown origin, hypertrophic pulmonary osteoarthropathy caused in CA bronchus, thrombophlebitis, visceral carcinoma, acanthosis nigricans. What are the tumor markers? Tumor markers are secreted in the blood, body fluids. They are secreted either in blood, body fluids, expressed on the cell surface. 3 locations measured by immunoassay. Histological sections, immunohistochemistry. Examples of tumor markers are for prostatic malignancy, prostate surface antigens, alpha fetoproteins measured in hepatocellular carcinoma, choriocarcinoma, beta HCG is measured, ovarian carcinoma 125C, colorectal carcinoma. Tumor growth of the tumor is autonomous. How does it depend? It becomes of its own. Breast estrogen receptors blockade, tamoxifen is used, estrogen receptor positive, better prognosis. Prostate androgen blockage, orchidectomy, lutein hormone releasing antagonist, anti-androgenic therapy. Thyroid, papillary follicular carcinoma, TSH suppress So thyroid suppression is thyroxine is given. Prognosis of the tumor depends upon the type, stage, grade, surface receptors, gene expression, sensitivity to treatment modules, age, nutrition. Staging of the tumor, TNM staging is done for colorectal malignancies, ABC, stage A, B, into the wall, through the wall, regional lymph nodes. Melanoma, Breslow's and Clark's method. How is screening? The screening has to be, principles of screening as it should be cost effective, common disease, established and effective treatment has to be there. Demonstrate that early diagnosis increase the cure rate. Diagnostic test available to apply for large population. High sensitivity and specificity. Test should not cause harm to the individual. Cost of the screening, large population must be justified. Screening programs for breast mammography has to be done 50 to 70 years age. Now it has reduced to 47 to 73 years. Repeat every 3 years. Cervix exfoliation identifies cervical neoplasia. Cervix every 3 years at the age group 25 to 49, 50 to 64 every 5 years. So this was regarding tumors, tumor markers, examples is tumor dependency, breast, thyroid, prognosis, tumor staging, cancer screening, screening programs. So this was about neoplasia. And let's go for the second topic, immunology. Immunology is a body defense mechanism. Body defense has specificity and memory. Two systems of defense are there in the body. One is innate and second is adaptive. Innate is non-specific nature. It has category are the components. Basically, various components act here. Physical barriers, skin, mucous membrane, mechanical cuffing, ciliary reaction, humoral secretions, and antibacterial activity. For example, lysozymes in tears, complement, interferons, cellular, phagocytic cells, polymorph, macrophage, mast cells, basically natural killer. These are the specific factors in the innate type. And what is adaptive? It is specific or acquired, more effective. Mostly it is led by the cells, lymphocytes and antibodies. Essential feature of immune system. This is adaptive. The body gets adapted once exposed to some sort of antigen. Specified to particular antigen, different antigens are there. Memory first time may be slow response and non-specific. During process, memory cells are produced. So second and subsequent time, antigen is presented rapid and specific action. Other defense mechanisms are chemical messengers are polymorph, macrophage, mast cells, kinase, complement system. What is antigen? Antigen produce immune response, bind specifically to antibodies or T cell receptors. Immune system respond to antigen by in two ways: cell mediated and humoral. Cell mediated immunity is led by T lymphocytes and humoral is through the antibodies by B lymphocytes. B lymphocytes stimulate plasma cells which release immunoglobulin. Immunoglobulins are, it has got two arms, long arm and short arm is immunoglobulin binding site, FC, FB. This is the regarding immunoglobulins. You can see this is the humoral immunity. It has two arms, two chains, heavy chain, light chain. These are the two light chains, and here is the antigen binding site. Papain action is here. The immunoglobulins. You will see the types of immunoglobulins. Production of antibodies depend on different types of B lymphocytes in the plasma cells. Immunoglobulins are produced by B lymphocytes. Immunoglobulin molecule comprise light chains, kappa and delta, and heavy chains. These are the heavy chains and light chains. Molecules can instantly separate into fragment antigen body. Once plasma cell produce antibody of one class reactive with only one antigen. Antibodies by binding to antigen can cause, how does it causes? It causes lysis of the bacteria. If antigen antibody binds, lysis of bacteria, neutralize toxins, opsonization, surface coating. Antibodies are produced by plasma cell in the lymph nodes, bone marrow, and spleen. There are 5 classes of antibodies. So before that, let's go for some important thing. What is tumor necrosis factors? It is alpha P55 and 75. These are the receptors. It causes apoptosis, killer cells.